So I'm just checking regarding Botox injection, which is botulinum toxin injection. They are to prevent a muscle from moving for a limited time. These shots are often used to smooth wrinkles on the face, also used to treat neck spasms, sweating, overactive bladder, lazy eye, and other conditions. And Botox shots may also help prevent migraine. This Botox and botulinum toxin is one and the same thing. Over a period of time, over prolonged use, they can weaken the muscles. So that's why those who get that facial these Botox injections done, it is over period of time, it can affect the muscles. That is about a little bit about botulinum toxin. Yeah, this is one of the muscle weakness, allergic reactions are noted, loss of bladder control, and it is not recommended to take Botox if one is pregnant or breastfeeding. Some extra information on these injections. Then we have next area is burning mouth syndrome. Now, burning mouth syndrome is an oral sensory disorder without a detectable cause. So the whole, there is as such no detectable cause means there is no virus associated, there is no allergy manifested. It's without any proper detectable cause. It is diagnosed when other conditions that can cause oral burning sensation have been excluded. Burning mouth syndrome is more common in women, with the highest prevalence reported in women older than 70 years. The onset of burning mouth syndrome may be sudden following a specific event, example, dental treatment, and a significant increase in personal stressors. So elderly women and post-dental treatment or stressful situations can trigger it, or gradual and unrelated obvious event can also trigger burning mouth syndrome. It's often poorly diagnosed and managed because it's a diagnosis of exclusion. We exclude everything and then what is left, the symptoms, it is burning mouth syndrome. The characteristic symptom is a burning sensation of the tongue and less frequently coincident hard palate and mucosal aspect of lips. Symptoms can cause minor inconvenience or in severe cases prevent patients from conducting normal daily activities. In extreme cases, patients may exhibit suicidal tendencies. Most commonly, burning sensation is mild in the morning and increases in intensity as the day progresses. And this presentation has the best prognosis, the one which is mild in the morning and progresses daily. Other ones are more extreme, which are like throughout similar severity. Other signs and symptoms associated with burning mouth syndrome include parafunctional habits, example, unconsciously rubbing the tongue against adjacent teeth and hard palate, which can cause traumatic abrasion of the filiform papillae on its dorsal surface. So that is parafunctional habit is associated with burning mouth syndrome. Dry mouth, usually the patient's mouth would be dry, halitosis and dysgeusia. Now, a burning mouth syndrome, if it is suspected, initial workup is extensive and requires detailed clinical history, including a dental, medical, and medication history. Because burning mouth syndrome is a diagnosis of exclusion. Other causes of patient symptoms must be ruled out, such as local causes, mucocutaneous conditions, fungal infections, rough dental surfaces. And then we have systemic causes. We have to eliminate other systemic conditions which may lead to something similar like burning mouth. Hypersensitivity in patients who feel the problem is processes related. Hypersensitivity can be identified with skin patch testing, but this is rarely required. We would get to know about the hypersensitivity with some of the history which the patient says. Then drugs, like drugs that cause sensory neuropathy, taste aberrations, or salivary gland hypofunction. Some practitioners use questionnaires to assess impact of symptoms on the patient's mood and quality of life. The management of burning mouth syndrome is very complex. The most important component of management is helping the patient to understand the condition. That is, burning mouth syndrome is a chronic neuropathic pain syndrome, irrespective of likely initial triggers. Some patients may improve with discussion and counseling alone. So this is very important that it's a chronic condition. That's why and neuropathic in nature, not nociceptive in nature, where true allergy or true trauma is not present. So that's why sometimes discussion and counseling alone can relieve. It can be like auto feedback. The most important component of managing burning mouth syndrome is helping the patient to understand the condition. Other management strategies include lifestyle changes to modify a patient's response to external stressors. Example, relaxation therapy, time management, exercise, community group participation. Pharmacological management, topical or systemic use of psychotropic drugs like tricyclic antidepressants, anti-epileptic drugs, and clonazepam. Pharmacological management is the treatment chosen by most patients and requires specialist referral. So mostly patients prefer pharmacological management over the lifestyle changes. That's all about a short note on burning mouth syndrome. The patient would actually present as the whole mouth burning sensation, which is typical of like with associated features like dryness, halitosis, and things. The next area is bruxism. Bruxism is a repetitive teeth clenching, teeth grinding, or bracing or thrusting of the mandible. So bracing, thrusting of the mandible also, not just grinding, but some people have the habit of constantly thrusting the mandible. So that is also a part of bruxism. It can occur during sleep or when awake. Etiology is very complex, multifactorial, but is not fully understood. There is no evidence that occlusal factors cause sleep bruxism. So it is not the patient is trying to bite in a high point, or occlusal factors does not produce bruxism per se. In sleep bruxism, rhythmic masticatory muscle activity peaks in minutes before the rapid eye movement sleep, before the patient goes into the deep sleep, suggesting that its onset is related to sleep stage transitions. Tooth grinding during sleep, which is usually noted by a sleep partner, is common. However, in the sleep laboratory, approximately 50% of the people with a history of tooth grinding have low frequencies of the jaw muscle contractions and tooth grinding. It remains to be clarified when tooth grinding becomes a disorder associated with negative consequences such as tooth damage and pain. So can tooth grinding associated, can it in itself lead to negative consequences of tooth damage and pain? It is not a very clear establishment. It's not, remains to be clarified. Bruxism may rarely be a sign of orofacial dyskinesia or occur following a head injury. Acute oromandibular dystonia, that is, the muscles have have a painful tonicity. Tardive dyskinesia caused by dopamine antagonist or antiemetic drugs like metoclopramide, chlorperazine, and antipsychotic drugs may be mistaken for bruxism. So this is deficient or a painful tonicity of the musculature after having these drugs is not bruxism. Okay, so bruxism is habitual in nature. How is bruxism managed? Identify the cause and address any triggers. Identifying the cause would be it's like a complex etiology. So one needs a referral to psychologist or a psychiatrist, if possible, which may require multidisciplinary approach. Sleep bruxism can be managed by avoiding risk factors, following relaxation techniques, hypnotherapy, biofeedback, cognitive behavioral therapy, and improving sleep hygiene. So regularly sleeping at the regular times, having the light switched off before sleeping, trying to induce very positive, like those we have music nowadays, that instrumental musics which are for sleeping well, and some yogic musics which relaxes the brain, or meditative musics are available for sleeping. They can assist well in calming the mind and letting the patient sleep. Management of awake bruxism requires habit recognition and reversal, and stress management. There is no evidence of hypnotherapy, biofeedback, or cognitive behavioral therapy for awake bruxism. There is insufficient evidence to support the use of drugs in the management of awake or sleep bruxism. And drugs are also not much evident to relieve it. What are the common triggers of bruxism? Caffeine, alcohol, smoking, snoring, obstructive sleep apnea, stress and anxiety, antidepressants like SSRIs, SNRIs, antipsychotics, amphetamines, and cocaine. So these are all triggering factors for bruxism. Full coverage intraoral occlusal appliances, splints, and dental guards can be used to protect the teeth from attrition during sleep bruxism. So they should be only acting as agents to prevent trauma to the teeth. They should be custom made by a dentist with appropriate expertise or an oral medicine specialist, regularly reviewed and adjusted as required. In addition to preventing tooth damage, intraoral occlusal appliances reduce muscle strain and loading of TM joints. However, they do not cure bruxism. The key is this: they just reduce the muscle strain, they prevent direct trauma or indirect injuries to the TM joints, they prevent occlusal surfaces of the teeth, incisal surfaces to be injured, but they do not cure the bruxism. Partial coverage splints should not be used because of potential for significant occlusal changes and risk of aspiration. So they should be full coverage splints should only be used. That completes our bruxism short note on bruxism. And the next session, we would start with trismus. Right? Okay, we can complete trismus, and it's a very short note again. Trismus as such is the reduced ability to open the jaws. That's the complete meaning is reduced opening of the mouth. And there are large number of potential causes, some of which are serious and warrant urgent treatment. Previously, trismus was only associated with a couple of causes, but now the range of causes, after a lot of experts have given, it could be because of the TMJ disorders, it could be because of temporomandibular joint derangement, basically the disc has deranged. Oral infections can reduce mouth opening, pericoronitis, spreading odontogenic infection, peritonsillar abscess, surgery, hematoma following dental injection. It's one of the common thing. After a swelling or a hematoma happens, patient has a reduced opening. Then we have a tetanus, acute dystonic reactions, oral submucous fibrosis, where fibers are formed in the muscle, buccinator, buccal pad of inside the oral mucosa, and head and neck radiotherapy. There is a case in ADC Part 2 regarding hematoma following dental injection, and the patient complains that I cannot open my mouth. So yes, trismus and these causes, they have correlated and created a case of trismus and hematoma. Accurately determining the cause of trismus requires a thorough history. So we need to ask that patient, what did that, how did it happen? How much does he find it difficult in chewing? And how many fingers can go in, and the detailed history we would need to take. Has it got worsened, and is it painful? Though there is not much of the active treatment which can be done if it is due to dental injection. When the circulation will settle in after 7-14 days, it would improve, and it would take maybe 4 weeks to 6 weeks for it to completely settle in. So accurately determining the cause of trismus requires thorough history, examination, and sometimes imaging. Promptly initiating management can improve outcomes. Management is tailored to the cause and may include dental treatment, physiotherapy, or the use of passive range of motion devices. Patients with ongoing trismus require prompt specialist referral to investigate less common causes like malignancies involving the TM joint or masticatory muscles or scleroderma. So we have, if patient has trismus for long, then we need to refer to specialists to find out what else could be a chronic problem in there, like malignancy involving TMJ, muscles, or scleroderma. So this is all about the short, small case-like descriptive areas which they have given notes on these topics. And in the next session, we will start with medical conditions, dental management of patients with medical conditions. Any doubt?